clinical vignette poster presentation, I will be discussing the complexities of iron deposition causing cirrhosis and the need to distinguish non-HFE hereditary hemochromatosis versus hepatic hemosiderosis in patients that receive a negative HFE gene study. I will be reviewing an interesting case of a patient with cirrhosis caused by an unknown etiology and the importance in diagnostic workup for appropriate treatment. The case involves a 71-year-old white man with a past medical history of non-alcoholic steatohepatitis, type 2 diabetes, and cirrhosis complicated by ascites. He presented to the emergency department with confusion, jaundice, and mild right upper quadrant pain for the past 2 days with 2 to 3 episodes of non-bilious, non-bloody emesis. His last hospital admission was a month prior due to complications from a hepatic hydrothorax. Pertinent family history includes his mother and 2 sisters passing away from liver disease of unknown etiology. He recently quit smoking after smoking for 50 years with 2 to 3 packs per day and drinks 1 to 2 beers a year. He has no history of illicit drug use. Upon admission, the patient was positive for nausea, diarrhea, and abdominal pain, and negative for fever, chills, cough, wheezing, or dyspnea. On physical exam, scleral icterus was noted with a positive fluid wave, moderate epigastric tenderness with normoactive bowel sounds, and jaundice. GI was consulted, and the patient was started on IV N-acetylcysteine, lactulose, zinc, Xifaxan, 5% albumin, and prescribed vitamin K for 3 days. During his hospital course, an extensive workup was completed. Bedside ultrasound in the ER showed minimal acidic fluid pockets for paracentesis, and the liver was coarse in echo texture. Lab work done to determine the cause of cirrhosis found a non-elevated acetaminophen level and non-reactive hepatitis panel. Workup for autoimmune hepatitis found an elevated IgA level with normal IgG and IgM, along with a negative anti-liver kidney microsomal antibody. Patient was negative for CMV and negative for antimitochondrial, antinuclear, and the smooth muscle antibody. Patient was negative for CMV and negative for antimitochondrial, antinuclear, and the smooth muscle antibody. The patient had both a negative alpha-1 antitrypsin phenotype and HFE gene was negative, despite a ferritin level of over 5,500. Transferrin was low and iron levels were normal. Haptoglobin was found to be low with high reticulocytes and LDH. CEA was high, but AFP was within normal range along with the marker CA19-9. Throughout his hospital admission, his MELD score stayed between 28 and 32, denoting an increased risk of mortality. Although aspartate transaminase and alanine transaminase levels were downtrending, they both remained high with a ratio of AST to ALT of about 1.5. Alkaline phosphatase levels along with direct and total bilirubin were also elevated during the course of stay. Elevated direct bilirubin levels suggest hepatocellular injury. Blood urea nitrogen levels and creatinine levels were increased throughout a majority of the stay. The creatinine levels were able to drop down as low as 0.9, but still not able to reach 0.7, which was the patient's baseline. The patient's MRI and MRCP results found diffuse iron deposition within the liver and a 3x3 arterial phase enhancing mass with washout and capsule enhancement at the junction between segments 4 and segment 8 concerning for hepatocellular carcinoma. Common duct is patent and measures 6 mm in maximum dimension. There is no intra or extrahepatic biliary ductal dilation, and the portal vein is patent. Because the etiology of the liver cirrhosis was still in question, a liver biopsy was performed and found benign liver tissue with hepatic cirrhosis of a fibrotic stage 4 and severe hemosiderosis/hemochromatosis of a grade 4, and 1 liter of fluid was taken off from paracentesis. The patient qualified under the Milan guidelines but did not wish to have a liver transplant. The patient left against medical advice with palliative care consulted. Unfortunately, the patient passed away 15 days after leaving the hospital. Although in this patient's previous medical workup he was diagnosed with NASH cirrhosis, it is essentially a diagnosis of rule-out, and given the evidence of iron overload on liver biopsy, along with type 2 diabetes, elevated ferritin levels, and a significant family history of cirrhosis, this patient's cirrhosis is potentially due to hereditary hemochromatosis and should be looked into. Although there may have been a component of hemolysis given the low haptoglobin, this does not deter from the fact that the exact etiology of this patient's cirrhosis had not been fully established, but could play a role in the patient's development of hemosiderosis if hereditary hemochromatosis is not the underlying cause. Hereditary hemochromatosis, a disorder of increased iron absorption leading to total body iron overload, is most commonly due to a mutation of the HFE gene. Although most common, a negative HFE gene mutation does not exclude all genetic causes of hemochromatosis. However, a well-known complication of cirrhosis is iron deposition as a result of hepatic hemosiderosis. Increased total body iron overload in hemochromatosis requires phlebotomy treatment or chelation, thus necessitating a proper diagnosis. This difference in treatment pathways underlines the importance of further genetic testing of alternative genetic mutations to fully evaluate other lesser common genetic mutations found in hereditary hemochromatosis. Some genetic mutations resulting in hereditary hemochromatosis include TFR2, FPN1, and HAMP. In the case of cirrhosis with evidence of excessive hepatic iron deposition without an HFE gene mutation present, non-hemochromatosis etiologies should be fully evaluated. Workup of non-hemochromatosis pathologies leading to hepatic hemosiderosis include a history of blood transfusions, the duration of cirrhosis, and further testing for thalassemia and porphyria. In the presence of cirrhosis with evidence of iron overload and a negative HFE gene, further testing to yield exact diagnosis should be sought to best guide the appropriate treatment.